Welcome to CSI Laboratories 10-color flow cytometry discussion. I am Elizabeth Stone, the manager for flow cytometry. I would like to present an interesting case to demonstrate the power of our new 10-color platform. You will see some unique combinations of antibodies that improve specificity and sensitivity, but most unique to our service is CSI's careful sample distribution, which 10-color flow enhances with more information on samples with limited cellularity. We will present 3 cell lineage assessments that we routinely utilize for comprehensive bone marrow and peripheral blood evaluation. We developed a powerful 4-tube, 10-color antibody combination, and the case shown here will illustrate how we employ 10-color to thoroughly characterize multiple lineages. The case we will review is a peripheral blood sample from an immunosuppressed patient receiving Imuran therapy. Although this treatment is associated with anemia, the patient presented with pancytopenia and therefore was given a hematology workup. We will demonstrate how our unique 10-color approach increases our clinician client's confidence when we identify an abnormal immunophenotype. CSI took the initiative to implement 10-color flow to assist in improving oncology patient management. Our 10-color approach improves the following: removes much of the inference of co-expression encountered when fewer colors are employed, decreases the turnaround time due to reducing the need for additional testing in the lab, increases the potential to identify unique phenotypes found useful in residual disease assessment, and most especially affords full characterization for the low cellularity samples. So let's look at this interesting sample and see how these prove to be true. Each tube employs CD45 as an anchor gating tool to segregate subsets in addition to using viability to ensure the removal of non-viable cells that can interfere with antigen expression assessment. The first tube of our 4-tube panel assesses B lymphocytes, kappa and lambda surface immunoglobulin, CD38, CD23, CD20, CD19, CD10, and CD5. Analyzing only viable cells throughout, we adjust our gates by right angle scatter versus CD45. The lymphocyte gate is shown here in red. This Boolean gating strategy will hold for all 4 tubes with the region colors maintained. Here you can see increased cells in our blast region, blue, few mature granulocytes, purple, and a monocyte gate, green. Next, see the 8 histograms that allow a primary quality assessment of each fluorochrom's performance. Here we assess the instrument, reagents, any sample issues, and the background staining used in determining positive versus negative antigen expression. For the sake of time, we have not shown all fluorochrome assessment pages. Look at the intensity of B-cell antigen expression, a critical aspect of expert analysis. Please look at the higher intensity of CD20 staining, approximately 10 to the 5th on this scale, compared to the CD19 intensity, approximately 10 to the 4th. At this point, we're ready to evaluate multiple 2-parameter combinations of reagents to elucidate the B-cell phenotype, quantity, clonality, antigen expression, cell size, and any heterogeneity in antigen expression that may provide evidence of a subset to interrogate in a background of normal cells. Viable CD19 and CD20 cells demonstrate excess surface kappa immunoglobulin with a kappa-lambda ratio greater than 8. A minor population of polyclonal cells are also present. With knowledge of a clonal process, we then evaluate additional 2-parameter histograms to determine if co-expression of CD5 or CD10 is present. The first row shows CD5 kappa restriction, and the second row demonstrates CD19 and CD5 co-expression with a lack of CD10 co-expression. Thus, we have identified CD19, CD5 clonal B cells. With this differential diagnosis, we need to understand the level of expression of CD23 and CD38 on the clonal cells. CD23 is not present on the 19 positive B cells and not significantly expressed on any CD5 positive lymphocytes. CD38 expression is partially expressed on the T cells present in this gate. They are CD19 negative, while CD38 is not significantly expressed on the CD19 positive B cells or CD20 positive B cells. CD38 also affords plasma cell assessment in this tube, though not in our lymphoid gate shown here. To summarize this tube, we have approximately 2.3% of the viable cells that are surface immunoglobulin kappa restricted B cells with co-expression of CD5, lacking CD10, CD23, CD38, and demonstrating increased expression of CD20. This is most consistent with a mantle cell lymphoma, and therefore, with this powerful single tube of pertinent B cell markers, we have put the clonal B cells in their proper diagnostic category to best assist in selection of further testing. Most important, in the situation where very few cells are available for flow cytometry testing, this tube, utilized as a standalone single tube assay, is used to characterize the majority of potential B cell abnormalities. Let's review the unique power of this tube's 10-color combination potential. So the following B cell phenotypes can be characterized with this single tube: CLL, mantle cell lymphoma, marginal zone lymphomas, follicular lymphoma, B cell acute lymphoblastic leukemia, hematogens, plasma cells, and large cell B cell lymphoma. A very powerful single tube assay to quickly characterize a B cell process with yet another 10-color feature. Less inference regarding co-expression than labs utilizing a 4, 5, or 8-color approach. Let's look at the T cell tube next. Again, CD45 in viability dye. Then you see the valuable CD57 used in TLGL assessment that many labs do not incorporate. CD56, CD8, CD7, CD5, CD4, CD3, CD2. For a comprehensive review for T cell aberrant antigen expression, CD4 and 8 ratio, NK cells, and TLGL cells. In addition, this tube provides 3 important T cell antigens that may appear on aberrant myeloid blast associated with MDS or acute myeloid leukemia, CD7, CD5, and CD2. After assessing the ungated, color-coded regions from CD45 gating for reactivity with each fluorochrome, we turn directly to 2-parameter histograms to assess normal and abnormal T cell antigen expression. T cells are evaluated for subset distribution, for instance, the CD4-8 ratio and the T-sum. In addition to subset deviation from normal, we quickly see over and under expression, lack of expression, or abnormal co-expression. With knowledge of normal antigen distribution, this subset review allows assessment of potential viral infections, peripheral T-cell lymphomas, Sézary syndrome, TALL, or TLGL. This case has CD57 positive, CD3 positive cells color-coded, demonstrating an increased amount of TLGL cells. They are greatly elevated at approximately 49% of the lymphoid cells. Our gating strategy is enhanced by the color gating of the CD57 positive to compare this subset's antigen expression patterns to the normal cells present, shown in red. See diminished 5 and 7 when compared to the normal T cells in red. The T cell assessment reveals reversed CD4-CD8 ratio and increased TLGL cells with co-expression of both CD4 and CD8. So you've seen a marvelously comprehensive assessment of T cells utilizing 8 monoclonal antibodies, CD45, and viability in our new 10-color platform. The antibodies you see in the last 2 tubes of the 4-tube comprehensive assessment primarily relate to blast, myelocytic or monocytic cells, and also utilize some redundant non-billable markers. These assist in confirming co-expression with CD34 blast, in addition to determining the presence of atypical maturation patterns useful in myelodysplasia assessment. Here, with only viable cells characterized, we notice markedly increased cells in the blast region, color-coded blue. Below, with side scatter plotted on each y-axis, we see the phenotype of the myeloid blast emerge. They are 34 positive, CD117 positive, HLA-DR positive, CD33 and CD13 positive, while lacking the mature marker CD16. So with these powerful pairings in 10-color testing, an AML is characterized. This set of 2-parameter histograms allows us to further confirm the phenotype and the true percentage of blast within the viable cells. It is especially powerful in the 10-color combination when mixed CD34 positive populations are present. For instance, when normal myeloid blast and hematogens are present, one can easily quantify each type. So we have 24% as the most accurate estimation of involvement, as the combinations shown purify and quantify in 2 separate ways to increase accuracy. 24% blast with co-expression of 34, 117, 33, and DR, a classic myeloblast when the other markers of the 10-color assessment are also considered. CD13 positive, lacking 16, negative for T-cell antigens, and negative for CD19 and CD10. Demonstrating once again the added power of 10-color, consider the need to monitor this patient as AML is treated. This 2-parameter histogram from our tube number 4 demonstrates that these blasts also aberrantly express CD123. This marker is useful in assessing normal samples, but we demonstrate here the discovery that would probably not be made in an analysis employing fewer markers. This valuable information of the complete phenotype of the AML blast provides the clinician with a phenotype not found in normal regenerating blast. This is pivotal to evaluate post-treatment cases for involvement with the primary leukemic blast. CSI often performs targeted special 10-color tubes to employ these unique and required markers in a single tube for low cellularity samples, such as ruling out central nervous system involvement, or especially for post-induction samples where we are searching for the diagnostic atypical blast. In conclusion, our patient's peripheral blood has AML with 24% atypical myeloid blast, peripheral blood involvement with possible mantle cell lymphoma, and increased TLGL cells, and no additional flow cytometry testing was needed. Any downstream testing is more easily determined, and we have a unique phenotype of the aberrant blast for following the patient. So let's summarize the power of CSI's 10-color flow for this case in all patients, whether analyzing tissues, fine needle aspirates, bone marrows, bloods, or body fluids. Inference regarding co-expression can be a concern in 4, 5, or 8-color flow. Seeing the co-expression in the same tube eliminates this inference and can eliminate additional testing to confirm co-expression. With no additional testing, time and cost are reduced, especially important in the cost containment aspects of this science. Identification of a phenotype sufficiently different from normal regenerating blast is paramount to accurate assessment of continued involvement in post-therapy follow-up samples. Low cellularity samples such as fine needle aspirates, spinal fluids, bone marrow core biopsies, severely leukopenic patients, and samples where it was difficult to obtain ample cells can be characterized in a single 10-color tube. Remember the numerous categories of B-cell lymphoma our B-cell tube could prove. We often specially design tubes to demonstrate aberrant target populations. Now that you have seen how CSI employs 10-color flow to increase sensitivity and specificity, in addition to time saving and sample conservation, we invite you to utilize our comprehensive services. At CSI, we are all devoted to improving oncology patient management by cautiously approaching every case to maximize pertinent clinical information, sharing each valuable sample between our departments in a tightly controlled manner, and applying evidence-based testing decisions at every opportunity. We encourage you to contact us with any questions or to schedule a visit to our laboratory. Thank you for your time.